as Dr. Dipendra has already told you, that this is a case which has been previously discussed. Both we have discussed the clinical features of this case when he came to our OPD, and thereafter this patient was operated. When we discussed the surgical aspects of the case, and I showed you some photographs from the surgery which was performed. Thereafter, at about somewhere around 6-7 months, this patient's follow-up was also presented. But at that point in time, the time period elapsed was only 6 to 7 months. And today, I'm presenting the 1-year post-op follow-up of the same patient. To recap the history of this case, the patient, when she came to us, was a 2-year-old girl. She developed a swelling in the right thigh when she was just 3 months old. And this swelling was not associated with any fever. And the parents took her to a local practitioner who performed some sort of an incision and drainage and prescribed some medicines. And with regular dressings, ultimately the wound healed. But the information which was most disturbing was that this patient, though she was now 2 years old, had never walked in her life till that point in time. Normally, you all know that it's around 1 year of age that a child starts walking. But in spite of the fact that the child was 2 years old, she had never walked. And this is the photograph of the patient in the outpatient department more than a year ago. We noticed that this patient was only able to stand with support, either support of an object like a stool, or the parent of the child would have to hold the hand of the patient. And you can see that the child is using an equinus compensation to get some sort of a support from the floor. On comparing, it was quite obvious that there is a significant amount of limb length discrepancy. The affected limb was short, and this was reflected by the difference in the level of the medial malleolus. On the affected side, it was very much proximal in comparison to the normal side. On further examination, it was possible to elicit painless abnormal mobility in both the transverse as well as the antero-posterior plane. And so clinically, it was diagnosed as an established non-union of the shaft of the femur. The X-rays of this child revealed a significant gap in the femur. And these are the AP and the lateral pre-operative views of the X-ray, which was taken. And as far as the AP view is concerned, since the opposite thigh has also been included a part of that, you can see the amount of shortening which is there. Along with that, it was noticed that the physeal plate, the growth plate, was probably not visible, and there was no bone proximal to where the growth plate is supposed to be. So this was the condition. You can see the tapering end of the bone, which is the medullary canal is closed. The bone ends are sclerosed, rounded off, which are all radiological features of a non-union of the atrophic type. Even in the lateral view, the same changes are seen. Sclerosed bone ends, a rounded off fracture site, and closed medullary canal. And you can see that the distal end of the femur, the condylar part, is very well preserved without any evidence of the growth plate being there. So, as far as the management or the treatment of this patient is concerned, the primary goal in such cases was discussed that it is union across the gap non-union side. The secondary aim would be correction of the limb length discrepancy, but what we were trying to achieve was that we should achieve some sort of a union so that this patient can start bearing weight on the affected limb, since the child was 2 years old and had never walked on that. So the modalities which were discussed was we could have used an Izarov fragment transport procedure or some sort of a bone graft. And since the patient was a very small child, fibular bone grafting, either free or vascularized fibular grafting, was considered to be a good option.